Welcome to the RightCare Virtual University Best Practice, where we are broadcasting today from Southern California, Northern California, and Minneapolis, Minnesota. The meeting will start promptly in a few minutes at noon, West Coast time. It is being recorded, and we currently all have participants muted. Please submit any questions using the Q&A box at the bottom of your screen. And if you have comments, please put that into the chat box. We'll be monitoring both of those. There are 2 hours of CME available for meeting attendees. Those will be issued automatically to those who are participating via Zoom, where they can see the slides. And with that, the webinar will be opening. And
thanks, Bob. We got 1 minute.
Well, it's lovely everybody's joining from across the state and even from some other states. Carol Zaher, cardiologist from Los Angeles, will be leading off the meeting as our longtime co-chair for our Los Angeles group, which is now virtual, and so we're extending it to a much broader geography.
Thank you, Hattie. Yes, welcome everyone to our virtual meeting. We've had to change our format a bit, but I think it's rather exciting that we now have a broader reach with all the regions that the RightCare Initiative has. And I think that we always strive to present scientifically sound and innovative ideas for our goal, which is, as you see on the slide in front of you, the drive towards zero preventable heart attack, stroke, diabetes, heart failure, deaths, and disabilities through best practices. So I will just say that we started to look at the schedule for this year at the end of last year, and Hattie had actually suggested, that the month of May is an interesting month, and perhaps we should try to do something even more special than we always do. And as I look at what the month of May symbolizes, which is basically one of the spring months of rebirth and rejuvenation and new beginnings, I think that's very appropriate for where we are in this day and age now, and with our goals in mind toward preventable heart attacks and deaths. So that we look at this as a new beginning, and some of the presentations today have to do with that. And also May does hold Mother's Day in our hearts. And so one of our presentations also is very well intent on that motive for looking at women in heart disease. And so I hope you find the presentations today very enjoyable and informative and helpful. We do have several of our co-chairs here today, and you're going to be meeting them as the meeting progresses. So I won't introduce them right now. You've seen that on the agenda. So I'm going to transfer over to Hattie, our stalwart leader, whose mission in life really has been well founded in the RightCare Initiative. So Hattie, how about a few words from you?
Well, welcome everyone. I just so appreciate the dedication of this group over the last more than a decade, coming together, getting to know each other, working collaboratively on the great cause of driving down heart attacks, strokes, and diabetic complications. We've added heart failure thanks to a couple of our leaders who brought to our attention this growing problem in our society. So Keith Emmons and Cindy Jambroni are the co-chairs of that group. And like me, they share the family experience of losing family members early to cardiovascular disease, as is the case for many of our leadership. So the dedicated passion for this work keeps us together moving forward. And the goals that we've created are very scientifically important, and even more important perhaps today, because we have seen that when you control blood pressure, lipids, blood sugar carefully and scientifically, we have in one community which was intensively treated driven down acute myocardial infarction hospitalizations at its height by 26% quite quickly, and that has leveled off to 22% and much faster than secular trend. So keep an eye on the important, these three sort of, perhaps to the medical community, they are boring. These old-fashioned, well-known risk factors: lipid control, blood pressure control, blood sugar control. And I have to tell you a little story. When I, in 2013, when I very badly broke my ankle to the point where it was a trimalleolar fracture, which meant my foot was actually disconnected from my leg with all the bones broken there. So I learned about how pain drives up blood pressure. And that's one of the things that we need to keep in mind as we are trying to control these things, that there are alternative things than medication that can help with blood pressure control. So when I had that ankle break, by the time I got to the emergency room, my blood pressure was so high. I was like, oh my goodness, I'm going to have a stroke and die just like my mother did. So I started doing deep breathing exercises while they started the morphine. And that actually really, you could see it starting to bring the blood pressure down before they were able to get the drip in. So as I recovered from that, I have to say I was very grateful for our scientific community and for reading on July 3rd, 2013, the JAMA article about adding clinical pharmacists to the care team. And this work was done by Health Partners Minnesota, who's with us today, thanks to Bob Trine, our operations lead for Los Angeles, who happens to know the CEO of Health Partners Minnesota. And when I was telling him about how a moment was a historic moment for blood pressure control, because here you had the Journal of the American Medical Association, the primary group that's been resisting adding the powerful pharmacists to the care team, having as their lead editorial, let's take it to the bank, let's do for blood pressure what we have done for banking. And Steve Chen will be talking about that further in just a minute, but I really appreciate that all of us use our networks to bring people together who can help teach each other how to effectively deploy best practices. So that's what our group is. And you can go to the next slide, please. So I want to thank the amazing group of people who have come together to support this grand endeavor, including the, first off, the University of California, our mothership, as well as the University of Southern California, the California Department of Public Health, the Los Angeles Department of Public Health. Blue Shield of California has been a magnificent help to us, as well as Amarin, Amgen, Boehringer Ingelheim, Genentech, Johnson & Johnson, Novo Nordisk, Ralph's Grocery Company, the California Healthcare Foundation. Judith and Jack White were some of our initial early true believers. So it's too much to name all the people who've been involved. Rand Corporation has been a home for us, as well as Stanford University, the Sierra Health Foundation. This truly is a public-private partnership that has been going for 12 years, and it builds and builds and builds, so that we now have with us in this group multiple states now participating, now that we've been able to go virtual, which is a beautiful, beautiful thing. So we have Florida, Nevada, Minnesota, Wisconsin, others that are engaging in our work, including our wonderful partners at the Centers for Disease Control and the US Million Hearts program. So with that, could we go to the next slide, please? So as we go to the next slide, I just want to mention that the Health Trust of Santa Clara has been very engaged with us recently to try to help us further engage the community clinics. And we do have many community clinics on the phone with us today or on the video today, and we have many experts with us. So it's too much to go through all of our experts, but I want you to know that on our website, we have a packet of data and briefs about the substantive material that we've gone through, which you can download. So I realize that this slide is very small, but I want to acknowledge that we have built 4 regional communities in California over a period of 12 years and have done significant statewide work as well. So I am so grateful to our many, many leaders that are with us today from across the state. And could you go to the next slide, please? You can find information about our leadership online. I think we may be having a little bit of a delay time on our slides. So I want to express to you the importance of using data to drive quality improvement. And you see here, really the main message here is the variation. And although we know that some of this data is delayed and it's imperfect because it's extremely difficult for the independent practice associations to record their true performance, it does help drive organizations to better adoption of best practices when they can see how they compare to their peers. So we've had some extraordinary improvement over the time of this project across our medical groups. Next slide, please. And the next slide is our triangle of promising interventions, which many of you are familiar with by this time. And I just want to point out to you that the 3 main components are patient activation, using clinical protocols, and adding the clinical pharmacist to the care team. And with that, I want to hand the meeting over to Dr. Steve Chen, our co-chair for Los Angeles, who has been presenting and part of our group, I think, since 2008. So you're such a hero in this world of spreading best practices for this. And I have really enjoyed testifying with you at the Capitol to try to bring this innovation to benefit more patients and families. So I want to thank you all for nurturing this project and your communities to have better outcomes. And with that, thank you, Steve, for introducing Health Partners Minnesota.
Thanks, Hattie, and always a pleasure to work with you and getting voluntold by you. It's always fun. Next slide, please. So for those of you who know Hattie, and she started to get into the background of this, the moment this article came out in 2013, she sent it to every single one of us and everyone else in the nation practically. She was so excited about this groundbreaking work, the fact that such a great outreach of patients were reached by telemonitoring involving clinical pharmacists. And then, next slide, please. When the accompanying editorial came out, that take it to the bank, I swear since 2013, Hattie, I've heard you say it about 50 or 60 times. Just such an exciting little slogan. If you hit the next slide, the last paragraph, last sentence of this editorial sort of says it all. And there it is right there. If home blood pressure monitoring and team-based care were implemented broadly, hypertension management would be easier for patients. The magnitude of blood pressure reductions brought about by this change could lead to substantial reductions in cardiovascular events and mortality, which is something patients, clinicians, and policymakers can take to the bank. And again, I've heard Hattie say it about 60 times, and she was determined to have this group of experts speak, and this is a great day for RightCare. So I'm really thrilled you're all here. Next slide, please. And it wasn't just a one-time shot, was it? Because there's follow-up research now showing that this is a sustainable intervention. It actually works years down the line. So really excited to hear about the initial research and the long-term follow-up that will be presented shortly. Next slide, please. And it really hits along the same tone of that innovation that we heard from our late friend, Dr. Ron Victor from Cedars-Sinai and his barbershop-based Pharmacist project, where he was able to achieve roughly 90% attainment of blood pressures below 140/90, which was the goal at the time of this project, as opposed to 32% usual care. You know, that sort of the spirit of that innovation and that, you know, thinking out of the box is right in line with what these amazing clinicians have done in Minnesota. Next slide, please. And I'm further thrilled because Hattie has been such a strong, as the entire group has, a strong supporter of including pharmacists on the care team. And let's be honest, we can train almost any healthcare provider or professional to titrate blood pressure medications. But the difference is, as you know, most of these patients with hypertension don't just have hypertension, aren't just taking hypertension drugs, they're taking a whole mix of medications. And to have a pharmacist available to troubleshoot for other meds, other conditions, other needs. I can think of my asthma patient who had high blood pressure, couldn't exercise because of his asthma, had to control his asthma, got him to lose weight, got him to get rid of a couple of blood pressure medications. I mean, there's a big mix of medications and diseases that pharmacists can have a big impact on. And that impact is financial, it's quality of care, it's harm to patients that could be prevented and avoided through optimal use of medications. This infographic that we created with California Department of Health summarizes those data points. Next slide, please. So the experts that we have today, so thrilled to have them, are Dr. Karen Margolis and Dr. Dan Rayrar. I made the mistake of trying to open Dr. Margolis' CV online. It crashed my computer. So fortunately, she sent us a condensed bio that I'm going to go over. Dr. Margolis is a board-certified general internist. She joined Health Partners in 2005 as a senior investigator. She was appointed executive director of research in 2017. She's a professor of medicine at the University of Minnesota School of Medicine and with an adjunct appointment at the School of Public Health's Division of Epidemiology and Community Health. Her research interests are in hypertension, prevention of cardiovascular disease, and women's health. She served in leadership positions in many large multi-center federally funded initiatives and trials, which I'm sure you've heard of unless you've been quarantined for the last 2 or 3 decades, some of which include All Hats, Accord, Esprit, which is ongoing, aspirin and reducing events in the elderly, another ongoing study, D2D, vitamin D and type 2 diabetes. She is PI for what she'll be talking about today, Hyperlink, a series of NIH and PCORI-funded research projects to study methods to improve control of hypertension using blood pressure monitoring, telemonitoring, and pharmacist management. Dr. Dan Rayrar is Senior Manager, MTM Programs and Community Pharmacy Partnerships. He's got his Doctor of Pharmacy degree from the University of Minnesota College of Pharmacy, completed a lengthy residency in pharmaceutical care and leadership. He established comprehensive pharmacy care services at Westside Community Health Services during that time period, transitioned to Health Partners, which is, by the way, the largest consumer-governed nonprofit healthcare organization in the nation, where he's currently responsible for managing the medication therapy management benefit provided to Health Partner members, oversight of the MTM program that provides care to Health Partners and Park Nicollet Medical Group clinic patients, managing pay-for-performance initiatives with community pharmacy partners, and directing Health Partners' managed care residency program. In addition to that work, he's active in the Pharmacy Quality Alliance, establishing benchmark quality metrics for pharmacy, currently serving as co-chair for the Quality Metrics Expert Panel. And I'll tell you, I've had the pleasure of hearing Dan speak several times. He's remarkably humble, considering he's one of the leading national experts in initiating, scaling up, and spreading sustainable comprehensive medication management programs that deliver high-value results. So really a pleasure to have both of these experts here today. I'm going to hand this off first to Dr. Margolis.
Thanks, Steve. I really appreciate the background that we got and the invitation to from Hattie and Bob and yourself to present today. And it's an honor to be describing our work here before for the webinar for California RightCare. So next slide. So I think this audience does not need this introductory slide about why controlling high blood pressure is important. It is the single largest contributor to all-cause mortality and cardiovascular mortality, and only 50% of people with hypertension are well controlled. This is a complex problem, or else we would have already figured it out by now, because that 50% mark for hypertension control has been kind of stuck at this level for about a decade. But we have some reasons for optimism. There are great tools and new opportunities to tackle this problem as systems of care. And research in our care group shows that home blood pressure telemonitoring with pharmacist care achieves the triple aim of better outcomes, better experience, and lower costs. So I hope you'll be persuaded about that as we go through our slides. And Dan will be co-presenting with me. We'll do a little bit of tag teaming as we go through the slides. Next, please. So Hyperlink is the short name for our NIH and PCORI project. And it's basically 3 projects that comprise about $10 million in federal funding. Hyperlink 1 started in 2008 and continued through 2013. This was a randomized trial that was looking at blood pressure control over a period of 18 months. And we were comparing routine face-to-face care in the clinic and home blood pressure telemonitoring plus pharmacist telephone management. And that program lasted for 12 months and included patients with uncontrolled hypertension. And we followed them out for an additional 6 months after the program ended. And I'll go into more detail later on. Hyperlink 2 is really the long-term extension of that project through 2015, and we followed everybody out for about 5 years, looking at their blood pressure in the absence of intervention for 4 years, and also looking at what kinds of cardiovascular events like heart attacks and strokes occurred in the 2 groups. And then Hyperlink 3, I'll touch on a little bit later, is our new pragmatic randomized trial that we started in 2017. And for this one, we're looking at blood pressure change over 2 years. And it's really being done in the field of primary care clinics. We're not using any research personnel to recruit or to execute the study or the interventions. And the patients are much more typical of routine primary care. And we've had a lot of input from both our colleagues in the care delivery system and also from patients who we have included on our research team and also on an advisory board. Next. So this is a complicated slide and I'm not going to go through it in detail, but this is just sort of a summary of what the literature shows on high blood pressure or home blood pressure monitoring. And at the top, you can see it's a meta-analysis of how much systolic blood pressure is lowered with various degrees of co-intervention or additional support given to patients in addition to giving them a home blood pressure monitor. And you can see from the top that systolic blood pressure is not really lowered significantly at all in people who just get self-monitoring and no other assistance. If you add a little bit of assistance, like some phone or web-based feedback, then blood pressure does lower. Systolic blood pressure goes down by about 2 millimeters of mercury, which is a small amount. It's not unimportant, but it's not enough to really move the dial on hypertension control in the country. Next slide. And you can see at the top here that if you beef things up, in addition to giving people the support of feedback, but also add education, then systolic blood pressure is even lower with this type of intervention, like about 4 millimeters of mercury on average. And then in the last grouping, this is where you're really adding a lot of intensive personalized counseling. And here, on average, blood pressure is lower by about 6 millimeters of mercury. And Hyperlink is one of the studies that was included in that lower group of meta-analysis. And there are a number of other people working in this area, including my colleagues, Bev Green and David McGid, who exhorted us to take it to the bank in that editorial. Next slide. So the rationale for combining pharmacist care with home blood pressure telemonitoring was pretty simple. Previous studies showed that nurse or pharmacist-led care significantly improved hypertension control, especially when they could independently make treatment changes. And as I showed you on the previous couple of slides, adding that level of support to home blood pressure monitoring increases blood pressure lowering and the duration of effects up to 12 months. So it also just makes sense. Combining these interventions really should create a synergistic feedback loop. Giving patients the ability to self-monitor is so much more powerful if somebody on the other end is receiving the information and helping them make treatment changes based on that home blood pressure data. Next slide. So Dan, I'm going to turn it over to you for the next couple slides to talk about pharmacists as members of the care team.
That sounds great. Thanks, Karen. So we're just going to take a little bit of an aside before going on and talking more about the research results to talk about what did the pharmacists do who were involved in the actual program. So I think most clinicians, most of you on the call would probably look at this wheel and think it's pretty no-brainer. This is how we provide care. We ask for information, we assess it, we create a plan, we implement the plan, we follow up, make sure it worked, and we continue that cycle. But in pharmacy, I wouldn't say that that's necessarily been the standard practice for pharmacists, especially if you put them in team-based care in a clinic. I think a lot of times what you see is kind of the first half of this wheel where a pharmacist will collect information, they'll make an assessment, and then they'll participate in the plan or make a recommendation and then rely on others in the care team to sort of take care of implementation and follow up. So there's more of a person who makes recommendations to the rest of the care team to implement. And comprehensive medication management, which is the practice model of pharmacists in our care system and what we pay for as a health plan for pharmacists in our communities, really forces the pharmacist to take responsibility for the outcomes of the medications that they're adjusting. And it's a whole person view of the patient. So we're specifically talking about hypertension here, but as Dr. Chen mentioned, early on, a lot more goes into optimizing medication use than just their blood pressure medicine. And while their blood pressure may be out of control, it may not be the blood pressure medicine that's really the issue that's at hand. Next slide. So just to paint a picture of what things look like within Health Partners, within the setting for the Hyperlink trial, the pharmacists that are providing the care for the trial are co-located in Health Partners primary care clinics. So these pharmacists are providing care in an office just like the doctors, nurse practitioners, physician assistants are. They're in an exam room, co-located, have direct access to the providers and other care team members that they're working with. They have access to the EHR, obviously, and they do their documentation in the EHR. And by the point that the study had happened, there was trust that had been built up by the working relationship between the pharmacists and the care teams, and collaborative practice agreements were established that gave pharmacists prescriptive authority and the ability to offer lab tests that they could use for testing efficacy and safety of the medications that were being used. And this crosses a variety of disease states, so hypertension included, as well as the most common ones that you think of diabetes and respiratory diseases, opioid use. So I think there are 14 different disease states covered by the collaborative practice agreements today. And really that focus is on optimizing medication use and outcomes. So the hypertension medications are a part of it. And we know that the people that were showing up here as a part of this study had out of control hypertension was obviously a focus, but the focus goes beyond just those hypertension medications. I'll give it back to Karen to continue talking about Hyperlink now. Next.
Okay, so our first trial, as I said before, is a randomized trial, but we randomized clinics rather than individual patients. We had 16 primary care clinics at Health Partners that had MTM pharmacists embedded within the care teams. And we recruited adult patients with blood pressure greater than or equal to 140/90. That was, we screened through the EHR to find them, but we confirmed it in a research clinic. And we randomized the clinics to two groups, usual care, so regular face-to-face primary care, and the telemonitoring intervention that combined pharmacist-led care management and home blood pressure telemonitoring. And we did research visits to measure blood pressure at 6 months, 12 months, 18 months, and then 54 months. And then we also gave patients surveys at those times as well. Next. And just to go into a little more detail about the telemonitoring, the home blood pressure telemonitor came from a commercial vendor. It transmitted and the stored blood pressure to the pharmacist via a password protected website. And we asked the patients to measure their blood pressure in the morning and evening 3 days per week, and to send us at least 6 readings per week. And the pharmacist care management, as Dan has described, was fairly comprehensive. We did a first visit face-to-face and then by phone every 2 to 4 weeks for about an intensive period of about 6 months. And they adjusted antihypertensive therapy using the algorithm from the collaborative practice agreement with the primary care. And the emphasis was also very much on lifestyle strategies and medication adherence, not just increasing and intensifying medications. So the intervention was 12 months long and we observed post-intervention. So the intensive phase was for about 6 months, and then the next 6 months was more of a maintenance phase with blood pressure monitoring going on, but phone visits only 3 times over that 6-month period. And then we had the patients return the telemonitor, return to routine primary care, and then we just observed them for that time period. Next. So this is a little bit about the patients. Their mean age was about 60, mean blood pressure 148/85. They were on an average of 1.5 antihypertensive drugs. A little less than half were female. Most were non-Hispanic white, but about a third had either cardiovascular disease or diabetes or both. Next. And this is the main results. So this is looking at blood pressure control. So everybody starts off with 0% control. And by 6 months, the telemonitoring and pharmacist care group was up to about 72%, compared with the usual care group at 45%. And the telemonitoring group stayed up in the 72% range for the whole 18 months that we followed them in the original study. And while the usual care group crept up, they never achieved the same results as the telemonitoring group. Next slide. And this comes from the home blood pressure data that we got from the telemonitoring group. You can see that blood pressure came down very rapidly by about 20 points from the mid-140s to the mid-120s. And that difference was mostly achieved within 4 months. And then thereafter, they were able to maintain the blood pressure at that low to mid-120 range for most of the time, for most of that first year. And then we don't have any more home blood pressure data because we took away the cuffs. Next slide. This is a little bit of a busy slide. The red bars show the percent of times at each visit. So each bar represents a telephone visit where the medication therapy was adjusted. And this is including either adding a medication or a dose increase. And the first bar is where it's about 10%. That was our face-to-face intake visit. And then you can see that about 10% of the patients had a blood pressure medicine change adjustment at that visit, but then it really ramps up at the first and second and even the third telephone visit, where they start getting that feedback from the patients through the home blood pressure. So about a third had their blood pressure changed at medicine changed at the first 2 visits, and then about a fifth at the next visit. And then it kind of settles down to some sort of, lower level of intervention at each of the follow-up visits. And our blood pressure medication number is that green dotted, green solid line. And it was about 1.9 at the intake visit. It had been 1.5 at the baseline clinic visit. So a few changes were made even before the patient got to the first pharmacist visit. And then they sort of settled in at about 2.5 classes of medication. So that's really all it takes to really achieve that difference in terms of medication changes. And then there's, definitely some behavior change and adherence improvements and lifestyle that's probably contributing to this as well. Next. And I just want to show you a tool. When you're getting a lot of home blood pressure data, the regular EHR tools just don't cut it. And this actually comes from our Hyperlink 3 study, where one of our programmers worked on creating a tool to make it a lot easier to visualize the blood pressure data. And it doesn't take a lot of explanation for you to see that all of the diastolic blood pressures in this patient were below the goal of 185, but it took a little while for the patient to get most of their home blood pressures below 135. And this is the kind of visualization tool that really helps people make decisions, and it includes some toggling so that they can use different time periods, etc. I'm going to switch it over to Dan for the next slide. He's going to talk about what it takes sometimes for some patients to get to goal.
Thanks, Karen. So this again shows a visualization of what the blood pressure data looks like. And I'm giving you an outlier example of, a really complicated patient. So the vast majority of patients are pretty straightforward. And when you're aggressive with changing medication and doing things, they get to goal relatively quickly, like we saw. And, by 3 months even, we saw significant drops in blood pressures. But then we all know that there are those people that have really difficult to control blood pressure. And a lot of times it takes ongoing effort to make sure that you are going to get this person to goal. So I think this example, over 30 weeks demonstrates that with usual care, I think it would be really, really difficult to be able to put this much attention into adjusting blood pressure medicine. So you see, multiple times, multiple different choices of medication are used. And I don't want to go through individually to talk to you about all the different changes that were made, but you can see that the pharmacist is making decisions about which medications to change, trying things, seeing how things work, backing off when changes didn't work the way that they were expected to, trying new agents. And eventually in this patient, over the course of a 30-week period, was actually able to get to a controlled blood pressure. Very difficult to do in a usual care situation, I would say, and really, in my mind, demonstrates how having a pharmacist be involved on the team can manage these really difficult to control blood pressures. The skills that they bring to medication management allow them to handle complex cases like this. Next. This slide, I just wanted to illustrate for everybody. We talked before about how medications don't exist in isolation, and when you have hypertension, the hypertension medications affect the diabetes medicines, affect the asthma medicines, affect everything else. What this indicates is this is an example of within our health partners clinics over the course of a year, the the conditions for which medication therapy problems are identified by pharmacists that are working with patients. So you can see, obviously, we have a lot of hypertension, we have a lot of diabetes, we have a lot of cardiovascular disease, but it's not just those areas where the medications need to be adjusted. And if we focus just on hypertension, we have 4,000 problems that were identified over the course of a year. There's another 14,000 problems related to medication that don't get resolved if you're not paying attention to the bigger picture. So I just wanted to leave you with the note that the hypertension part is extremely important, but that the medications are beyond hypertension are also important. And then I'll pass it back to you, Karen, to move along.
Great.
Next
Okay.
slide.
So Steve alluded to our long-term follow-up study. And what you can see here on the left-hand side is the blood pressure data that we measured in our clinic. So we had baseline in the mid-140s, and then the big drop in the orange group, which is our telemonitoring and pharmacist care group, down to the mid-120s, and a lesser drop in blood pressure in the usual care group. And those differences persisted over 18 months. But then, we have a long gap there between 18 months and 54 months when our funding ran out and we got some more funding. And there's a little bit lower blood pressure by about 2 millimeters of mercury. But in this group of 450 patients, that was not significant at 54 months. And the right side is just a little interesting side note where we were that big gap where we don't know what happened between 18 and 54 months. We pulled the same patient's data out of the EHR, and you can see that the dark lines are the average blood pressures for that group, and the dotted lines are the 95% confidence intervals, and they don't really cross until 2 years. So it looks like we were able, with a intensive 6-month intervention and a little bit of maintenance, to keep people's blood pressure significantly lower for 2 years. But you have to keep working on it. It doesn't just stay forever with patients with hypertension. Next slide. But there are still legacy effects of that 2 years of blood pressure difference. And what we were able to show at our 5-year follow-up is that the intervention group is on the left, and we looked at heart attacks, strokes, heart failure, hospitalizations, coronary bypasses, and then added up all of those events. And there were 15 in the intervention group as compared with 36 in the control group. And while that difference was just short of being statistically significant in this small group of 450 people, we never really intended to show a difference in cardiovascular events. But if those events were really different between the two groups, then it would have saved the healthcare system almost $800,000, and that far outstrips the amount of money that we spent on the intervention. So there would have been a net savings, you can see up at the top in the title, of over $1,000 per patient in the intervention group. Next slide. So just a little bit about our current study that we're working on. Like Hyperlink 1, we randomized clinics to telemonitoring plus pharmacist care versus sort of a new and improved version of clinic-based care. So things have improved at Health Partners. We have all kinds of tools like registries that we didn't used to have. Unlike Hyperlink 1, though, we, instead of manually recruiting a small number of dedicated volunteers through traditional research methods, we used an algorithm in our EPIC electronic health record to find and enroll patients at their routine primary care visits. There were so many people who would have been eligible with blood pressure greater than or equal to 140/90 that we had to raise it to 150/95 in order to sort of be able to manage the volume. And we did aim to enroll many more patients, and we succeeded in that, as you'll be able to see on the next slide. So you can see that at the top here that we screened almost 60,000 patients with hypertension at our clinics, and just over, well, just shy of 3,800, or about 6% of the original group, had high enough blood pressure to qualify for the new study. But we were able to enroll almost 80%, or a little bit more than 80% of them, in Hyperlink. And by enroll, I mean that their primary care physician signed an order for them to get systematic blood pressure follow-up. And in our telemonitoring group, they were referred to a pharmacist, where they would be offered the telemonitoring and pharmacist telehealth intervention. And in our clinic-based care group, which is our new comparison group, they were referred to a medical assistant or a nurse to do blood pressure follow-up and continue their face-to-face care through that method. So that's the basic design of our study. We have just over 3,000 patients that were enrolled. And next slide. We are still in the process of following these patients up. Nearly everyone got some form of follow-up, 90+%, but only 1/3 of them went to the intended next step. So the nurse for the clinic-based care patient, or the pharmacist for the telemonitoring group within that first 6 weeks. They did get care, but mostly they continued to receive care from the more traditional face-to-face visits with their primary care physician in that other 2/3. But once patients did get to the pharmacist, there was very strong engagement. Over 90% of them agreed to sign up for home blood pressure telemonitoring and submitted at least one blood pressure. We were a little worried it would take a long time for them to get into the pharmacist, but it was on average about 3 weeks. So it was a little more than our 2-week goal, but we were pretty close. And on average, their home blood pressure telemonitoring duration has been 18 weeks, so about the roughly 4 to 5 months that we saw in our original study. And patients on average have been sending 6 blood pressures per week, as we were hoping for. Next slide. So as I said, I hope we'll be able to come back sometime in the next year or two to talk about the results of Hyperlink 3. But in the meantime, our research is really paying off with policy changes. So the American Heart Association, American College of Cardiology, and other expert groups have really strengthened their recommendations for home blood pressure monitoring and team-based care. In 2019, NCQA's HEDIS measure for controlling high blood pressure was updated to include telemonitoring as a way of demonstrating controlled blood pressure. And also new CPT codes have been introduced for remote monitoring and home blood pressure monitoring that cover the additional work for care teams of using this method to help take care of their patients with high blood pressure. Next. And just to mention that we are working with our care system in developing methods to bring this research into the routine care system. It's slow, as it is in a lot of places, but we feel that the whole dark cloud of COVID-19 has a silver lining in that it's really made telehealth at the forefront of care and brought down a ton of barriers. And I'll just have you go to the next couple slides and ask our presenters. I have about 2 or 3 more slides. Would you like me to finish those up, or should we take a break for Q&A?
I think you have a few more minutes.
Please continue. Thank you.
Good. So I just have a couple more slides to sort of summarize what we've found is, through our research and practice to be effective elements of team-based care. So it's really important to have a dedicated care team member to take responsibility for enrollment, teaching, ongoing monitoring, and using an evidence-based treatment algorithm. I don't think it has to be a pharmacist. I think pharmacists do a great job with this work, but I think it can be another care team member, including the physician, if they're really dedicated to and want to do this work. It's really important to systematically identify and enroll eligible patients. We saw how many people could have benefited from this program when we set up automated methods to identify. Providing patients with a low-cost, simple, validated blood pressure telemonitor is really key. And technology is our friend here because fairly inexpensive wireless Bluetooth monitors are really affordable now. And given how many people have smartphones, there are really excellent ways to get that data up into the cloud and into places where clinicians can access it with minimal difficulty. We have succeeded getting that home blood pressure data uploaded into the electronic health record. The data visualization tools are really important because the EHRs have really lagged behind in making that data user-friendly. Having the data go into the EHR is another important benefit, is that we can have a seamless method of alerting people when there are dangerously high or low blood pressure values. And if you have a lot of patients who are getting telemonitoring, it's going to be really important to have dashboard tools to help keep track of where people are in the system, who's missed a visit, who's sent data in, who hasn't. Next slide. These are some of the sort of softer things that are really important for effective care. Trust is huge. It took many of our patients a little while to warm up to the idea of seeing a pharmacist, but most of them would never turn back once they got a taste of it. Patients really gain insights from their own data. We've heard so many anecdotes about patients really telling us that they didn't believe that their blood pressure was high until they saw it again and again from their home data. It's important to have really clear criteria for intensification. In Hyperlink, we used a goal of getting 75% of the readings below the home goal of 135/85. But an equally effective way of doing that would be to use the algorithm that the Barber 2 study used, which was to try to get the average blood pressure below 130/80, which is the current recommendation from the American Heart Association. Personalized and flexible treatment, close attention to side effects, and really good communication with the rest of the care team are pretty key. And also criteria for a handoff. When intensive monitoring is no longer needed. And in our setting, we tried to use a blood pressure control at that more than 75% of readings at goal over 3 consecutive 2-week sessions. So that was what we used. There are probably other ways to achieve that. And next slide. And then I think our studies show that long-term follow-up is really key because patients won't stay under control forever. You can use, if you have an inexpensive home blood pressure telemonitor that's automatically uploading through the person's smartphone, you never have to take it away. But it's also perfectly reasonable to surveil the EHR. Patients are going in for visits many different places besides primary care, and it would not be very hard to set up a surveillance algorithm to alert the care teams to when patients' blood pressure looks like it's trending upwards. And then again, I've said this a couple times, I think you want to use the right team members at the right time. There is definitely room for health coaching. Our medical assistants were really key to the face-to-face care. RNs, nurse practitioners, pharmacists, dietitians, social workers, and of course, the physician is a key member of the care team, and we never want to forget the patient. I think this might be my last slide. And here's Dan's and my email addresses if you have any questions. Neither one of us are in the office, so you can call those phone numbers, but I don't know when we'll be back in to get them. So use the emails, and we'd be happy to answer questions or things that have come in through the chat.
Thank you very much. This is Dr. Zare. I'm quite impressed with those results you had on blood pressure. You know, at the RightCare Initiative, we're, if I can simplify it, we're looking for new solutions and approaches to old problems. And Hattie mentioned that we might, in general, as a profession, think hypertension is a little boring, but I think one of your first slides showed the impactful nature of hypertension as the largest cardiovascular risk factor, and something that we can control and really make a substantial difference. So I think that point has to be well taken. I have a question. Are there any barriers that you found to your program? We at the RightCare Initiative have been very positive about pharmacist interaction and telemedicine, although we're having a little difficulty getting it totally off the ground. Maybe now it'll be easier, but are there some learnings you had that you had barriers and you figured out how to maneuver around them?
I think the biggest learning, when we first started Hyperlink, the MTM program was just launching at Health Partners, and I was really excited about it, and they were very excited about what we were doing. But I think it takes a little while for both patients and some providers to embrace the team care approach. I think that a lot of physicians, after having some experience with working with our MTM pharmacists, recognize how much the pharmacist helped them get the patient to a place where they can actually do the visits effectively in the 15 or 20 minutes that are really allotted, because our MTM pharmacists visits are generally allocated to be 30 minutes or even an hour, and that's what it takes sometimes to go through these very, very long lists of polypharmacy. I might ask Dan to chime in here too.
It's hard for me to pick one. I mean, we could do a whole talk on the barriers to introducing a pharmacist into a practice. I think what Karen talked about is absolutely true. Building that trust. I think one of the things, maybe even like the silver bullet piece, and it's not brain science or brain surgery, but having somebody within a practice that is a champion of the service is incredibly important when you're starting. So if you're going to introduce a pharmacist into a physician practice where none of the physicians are on board, it's probably going to be really difficult to have success. So identifying those places where there are champions, going there first, and then letting the providers talk to each other about the value is the best tool I think there is for sort of establishing that trust between pharmacists and the clinicians.
May I ask a follow-up to that, please? And that is, during the era of COVID-19, are you doing joint video visits with doctors and pharmacists to do an introductory visit to patients who have out-of-control hypertension, and using your EMR to find those who need specific outreach for this?
We have not been. And, our practice is advanced at this point in time, so there's such strong trust between the referring providers. And I think patients get that when their doctor tells them, I really want you to go see this team member of mine, a pharmacist that's going to help adjust your medications. It's a hugely important piece in terms of the patient having the trust. So we haven't needed to do that. And, it's an interesting question about what do things look like going forward as we transition to having a lot more care done by telemedicine. What does it mean for team-based care if we're not co-located, where we build those relationships? How do we do that when we're sitting in possibly remote locations? I think it's a question that we're starting to we're thinking about as, as we want to expand into new locations where we haven't been before, or we're helping other practices in our state try to sprout up to start to provide care, so that we're able to do that for our health plan members where we don't have services today.
Yeah, there are a couple of questions in the chat box that I think I can address. One of them is from Megan Mulligan. Are you able to count home values for HEDIS? And the answer is you can count, well, let's talk about pre-COVID. Pre-COVID in 2019, HEDIS, the HEDIS measure was changed to allow blood pressure, home blood pressure that is measured digitally and digitally transmitted and interpreted by the provider. So telemonitoring the way we did it, where there is 100% fidelity, there's no missing values, the patient can't delete anything or falsely, falsify their blood pressure in any way, that definitely would count for HEDIS, and that seems to be a permanent change. I am told that in 2020, they are going to relax that because of the COVID issues, and they will potentially be able to count blood pressure that's reported to the physician. And I think we're going to have to wait for the official guidance to come out from NCQA. But I assume that once we go back to more normal operations, that HEDIS will continue with the acceptance of telemonitoring. And that's huge. I mean, doctors and care systems, are not willing to embrace something if it doesn't count for quality measures. So I do think that this was a really important change. And the second question is, how are they getting BP data uploaded into the EHR? So for our hyperlink research studies, we used a vendor, and the vendor worked with our IT department to work out the security arrangements for the blood pressure to be data to be transferred from the vendor's cloud into our EHR. The same methods are possible, I think, without a hardware vendor. You probably can, there are a number of software vendors that are marketing their services for transferring cloud data into the EHR. And if you have a really skilled programmers like we do, it might be possible to even do it without a vendor. But we're still exploring how we're going to do this without using an expensive vendor for the services.
Dr. Berg, did you have a question for our team?
I had a question for Karen Margolis. Karen, first, I'm really happy. Can you hear me?
You're a little muffled.
Can you hear me now?
Much better.
Okay. All right. We'll hope the dog doesn't bark. First, Karen, I am thrilled to have you here. And I know you share my interest in the cardiovascular care for women and their outcomes. And so I was very interested from the beginning on whether you saw any differences in those trends on medication adjustments for women compared to men, and then on the other end on the outcomes, the impact of this intervention on women versus men, particularly given the greater polypharmacy issues you typically see in women.
Yeah. Hi, Chloe. It's nice to see you virtually. We have not looked at the number of events by sex, and it's a good suggestion to do that. Interestingly, we definitely did look at the effects on blood pressure by sex, and surprisingly, well, maybe not so surprisingly, the bigger effects were actually in younger men. So sort of more the young invincibles. So it does seem that this intervention is actually particularly powerful for men. And the Barber study, of course, was exclusively in African American men. and had almost exactly the same results as Hyperlink. I do think that exploring the sex effects are interesting, and in our new study with 3,000 people, we have enough men and women to really look at that.
Oh, wonderful. And I hope you'll also continue to highlight the success in younger men, especially younger men of color, because we've seen in some populations, providers are hesitant to stigmatize young male patients with male African-American patients in particular with a health problem when it's hypertension, which is deeply disturbing. Given the consequences of beginning to have problems with allostatic load. It just puts them on such a worse trajectory. Thank you.
Dr. Margolis, I believe you have another commitment.
Yeah, it's a little loose. I want to make sure that I finished up here and answer everybody's questions. I can be a little bit late to my other meeting.
Carol, there had been one question on the brand of blood pressure monitor that was used.
We used the one that we used for this study was an A and D, which also has its blood pressure monitor brands and numbers and sources are a constant source of frustration to me. But that monitor's been kind of a workhorse that's out there, the 767. It's very reliable, it's very accurate. And the other monitor that we haven't directly used it, but we're very interested in is the Omron 7 series, which is a pretty cost-effective telemonitor. And actually, I want to put in a plug for a website that the AMA has recently stood up that provides a listing of a commercial-free listing of validated office and home blood pressure devices. It's called validatebp.org. I'm going to double check that while I'm here to make sure I'm not making that up.
And we have it linked to our website.
Yep, great.
Yeah. So the Omron 7 is something that the UC Berkeley professors train our students to do community monitoring with.
All right, well, thank you very much. I think success is a good step towards further innovation on our part. So thank you very much for that very informative presentation. So
I do want to say, as we transition, that Scott Flynn, who is now medical director with Blue Shield of California, was one of our early co-chairs in our San Diego work. And we had this work presented, not this exact study, but earlier work that we had done a comparative effectiveness trial with UC San Diego and Jan Hirsch and UCLA, and found similar results of very quick progress. And so Dr. Flynn started out as a skeptic in his medical group, and he found such good results that he started becoming a champion. And now at Blue Shield of California, he's been working to try to spread it across the state. So your work has been very, very formative in helping to shape California health policy. And we just can't say enough good things about your work and how much we appreciate what you've done.
Well, thank you very much to all of the attendees and to the organizers. And I'm going to sign off now. I hope to hear from you soon. Bye-bye.
Thank you, Drs. Margolis and Ray Rauer.
Thank you all.
Thank you. Bye-bye.
So Dan, will you stay with us while for a while?
I can, yeah, I can make it here for a little bit longer.
Thank you.
I've got about a half hour before I need to sign off, but I will hang out for that period of time if you'd like me to.
Thank you. Could you go to the next slide, please? So we're so pleased that our co-chair, Dr. Chloe Bird, is back with us today. And with that, I will hand it to Chloe to introduce our next wonderful speaker on women's health from UCLA, Dr. Tamara Horwich.
It helps to unmute. Thanks. I am thrilled to be able to introduce Dr. Tamara Horwich, who I've had the pleasure of being on panels with in the past. Dr. Horwich is an attending cardiologist and Health Sciences Associate Clinical Professor of Medicine and Cardiology at the David Geffen School of Medicine at UCLA. She's director of UCLA's Cardiac Rehab Program, including the Dean Ornish Comprehensive Lifestyle Program for Reversing Heart Disease, and co-director of the UCLA Women's Cardiovascular Health Center. I just want to say how excited I am that she's bringing her expertise across so many clinical interests, all of which have included a focus on understanding women's health issues. Her main interests, research interests, include studying obesity, body composition, cardiovascular disease, as well as risk factors and novel therapies for patients with heart disease. And she's been funded from the National Institute of Health, the Health Failure Society of America, and the Iris Cantor Women's Center at UCLA. Dr. Horwich is also a fellow of the American College of Cardiology and the American Heart Association, and importantly has helped draft the national guidelines on management of heart failure. So join me in welcoming Dr. Horwich.
Thank you, Chloe. It's so nice to be here today. I will, there we go. So again, thank you to everyone for having me today. And sorry, just fix my screen here. I'm going to talk about women's heart health, what we know, and what we're going to do about it. Mostly what we know. Next slide, please. So I'd first like to go back in history to one of the greats in medical history, who is the Canadian physician, Sir William Osler. And any medical student and probably any doctor has heard this name many times. He's known as the founder of modern medicine. He founded Johns Hopkins Medical School. He named many different syndromes. And this is how he wrote about heart attack. A typical heart attack patient is a keen and ambitious man, the indicator of whose engine is always full speed ahead, a well-set man from 45 to 55 years of age, with a military bearing, iron gray hair, and a florid complexion. And this description lasted for about the next 100 years. We didn't get away from this typeset of the male with gray hair. Anyway, next slide, please. And again, a big name in medicine, Frank Netter, was a physician who became a physician only because his father forced him to. He loved being an artist. He wanted to be an artist, and he ended up being the foremost medical illustrator probably any time. And there's many books that he's illustrated, and medical students around the world use it. And here is his picture of a heart attack. Again, we see the male with the gray hair holding his chest. We don't see a woman, and obviously this couldn't even be in California, so he's forgetting us too. Anyway, next slide. Because it's very cold outside. Heart attacks are known to be triggered by the cold. But time moved on, and eventually, finally, Dr. Bernadine Healy, a woman and a cardiologist, was named the head of the National Institutes of Health. And one of the first projects she started was the Women's Health Initiative. And this research project studying women revealed many things about, menopause and hormone replacement, and specifically also about heart disease. Next slide. And so we know today in the United States, cardiovascular disease is basically about equally prevalent in men and women. Of course, the prevalent increases as we get older, as you look to the 60 to 79 age group. And in the 80 plus age group, we see that there are actually more women living with heart disease than, than men. And that's the group that's continuing to grow, of course. Next slide, please. Just take a quick sip of water. And here we're looking at heart disease, and it has been the leading cause of death for both men and women. And we look back over the last 40 years, excuse me. And we see that in 1980, the death rates are pretty similar between men and women. The blue line is men, the red line is women. And around 1985, late 80s, we see a decreasing risk of, decreasing death rate of heart disease in men, but not women. And that's about the time that statins were released. Those of you who don't know, they're medicines which can drastically lower cholesterol levels and can prevent heart disease. And then as we go forward, we see the start of the Women's Health Initiative in the 1990s, and men's heart disease is continuing to decrease, while women's is not. And in the late 1990s was when the Women's Health Initiative found out that HRT was not beneficial to heart disease. It increased risk of clots, increased risk of breast cancer. So HRT, which is hormone replacement therapy for women, in menopause, was, stopped being utilized routinely. And then there were more awareness campaigns about women with heart disease. And so we see a decrease in the risk finally, in the rates of death from heart disease in women, culminating in around 2010. However, unfortunately, more recently, both women and men have been losing ground. That won't be the topic of today's discussion, and also, of course, is multifactorial. Next slide, please. So here's what I'll go over today. We're going to talk about coronary artery disease in women, heart failure in women, as we've heard just by our last speakers, how important that is, looking at unique risk factors in women and cardiovascular syndromes that are pertinent to women. And then last, what can we do? What are we doing? Next slide, please. So as I mentioned, we'll first talk about coronary artery disease in women. And yes, there are substantial differences from men. This picture is from the New York Times, which is many doctors' favorite medical journal. Always gets it right, gets the the key issues up there, and it's showing women what coronary artery disease can feel like in women. And I'm going to get into this more in a few slides. Next slide, please. Here we look at women in the UK. We have seen similar patterns here in the USA too. We're looking at change in coronary artery disease incidence, so new cases of coronary artery disease. And it's great when we look at the older women, 55 years of age, and men 55 years of age and older, we see there's a decreased incidence of heart disease, during the decade before 2005. And if you look down to the younger age groups, we see there's not much change in men. That's concerning. But even more concerning, looking at the 35 to 45 age group or the 45 to 54 age group, we see an increased incidence in women. And again, this is concerning. Enter, please. Or next slide, yeah. So this is the group that we're focused on. It's continuing to be seen that younger defined as 55 and below. This is a group of women at risk. Next slide, please, and we'll go over possibly why. So as we mentioned, heart attacks are decreasing in the overall population, but increasing in young women. Women also have been seen to have longer hospital stays and higher in-hospital mortality when they are admitted for a heart attack. Women compared to men are less likely to receive reperfusion therapy, which reperfusion therapy is basically you have a heart attack because an artery is blocked, and women are less likely to have medicine or procedures to get that coronary artery unblocked. Also, women compared to men are more likely to have delays in treatment. So here's some words that we use in cardiology: door to balloon time. So that means like when you get into the ER, if you're having a heart attack, the goal is to get women in, or to get any patient into the cardiac catheterization lab and get the catheter inside the artery that's causing the problem and open up that artery with a tiny balloon. And so women have delays in this. Also, door to needle time, meaning you get into the emergency room and then the time that we start the cardiac catheterization to try to fix that heart attack. Next slide, please. So possibly, you know, this is definitely playing a part. Women's symptoms of heart attack seem to be what, you know, quote unquote, atypical or more non-specific, not the heart attack that we saw of the man, you know, in the Netter anatomy book where he was clenching his chest, you know, it's my chest, it's my chest. So women may have chest pain or discomfort, but also they may feel nauseous, diaphoretic, even just unexplained fatigue, shortness of breath, lightheaded, body discomfort. So heart, you know, obviously these symptoms can overlap with many other disease etiologies. So a little bit harder to define heart attack based on symptoms alone. So this could maybe this is part of the problem of why women, especially younger women, are not doing as well. Let's keep moving. Next slide. And this was a really interesting study which looked at, it's not your typical doctor study, it looked at the healthcare experiences of young women with acute myocardial infarction and seeing, like, trying to dissect where are we going wrong. So is it the recognition of symptoms in women, like I discussed, you know, are doctors not recognizing, or are women themselves not recognizing they could be having a heart attack? And again, then the interaction with the healthcare system, like when they get to the hospital. So basically, some young women who had a heart attack were extensively interviewed. And I'll just show you a couple of the results, which I think are interesting. Next slide, please. Okay. So here's, you know, a transcript of what one woman said. I felt so stupid laying in the ER. The nurse comes in and goes, all your lab work, everything looks great. And I burst into tears like I'm so embarrassed. The nurse comes in, she's embarrassed that she came in and wasn't having a heart attack. The nurse comes in about 20 minutes later and goes, we need to move you to an ICU. You've had a heart attack. But it was a sense of relief. I was trying to justify it. I was mortified. You know, this woman was worried what people were going to think of her instead of worrying about her health. And this woman happened to be a nurse. Next slide. So that's getting in, you know, in the way of her going into the ER when she's having chest pain or other symptoms. So here's another woman. The healthcare system was not consistently responsive to young women with acute MI. This woman says, I remember calling a doctor and telling him I was having these chest pains and all that stuff, and they just scheduled me a regular appointment. I would not know that I'm having a heart attack. I would consider that it was the doctor's responsibility. They should have pushed me in faster or told me to go to an emergency room. So there's another roadblock for women, for especially young women, not being recognized that this could be a heart attack. Please, you know, go to your local emergency room. Next slide, please. And so coronary artery disease may also be more difficult to detect and diagnose and treat in women because it may develop differently in women. So when we look at these are examples of coronary arteries, and if we look at men, and please next slide, we see that men tend to have a focal stenosis. So just one blip there in the middle of the artery, and that's easier to detect than what happens in women. Next slide, please. Who may have more diffuse atherosclerosis. So when you look at the artery of a woman, and I'll show you how we do that, it may just look like a smaller artery because the plaque, the cholesterol, has built up relatively evenly the whole length of the artery. Next slide, please. And there's a new term we've come up with, we meaning cardiologists in general, called MINOCA, myocardial infarction in the absence of coronary artery disease. And this is more likely to happen in women, and therefore harder to diagnose and harder to treat. So here's a list of trials, big medical trials of acute coronary syndromes over previous years. Gusto, TIMI, trying out different medicines and procedures. And in each of these trials, women were much more likely to have MINOCA than men. So basically, women were brought to the cardiac catheterization lab. They were thought to be having a heart attack. But in, for example, this Gusto study, 30% of the time, the woman didn't end up having coronary artery disease identified. And this was across the board. And again, this may go back to coronary artery disease develops differently in women. And next slide. Here's what I'm going to show you: a coronary angiogram, the gold standard still for diagnosing coronary artery disease. Next slide. So when we do an angiogram, this is what we see. It's dye pushed into the arteries of the heart with an X-ray, looking at it. And this is what's done when a patient goes into the cardiac cath lab when a heart attack is suspected. Next slide. So a focal stenosis, again, on the angiogram can be easily seen. Next slide. So for example, you can see that there's a near total blockage in one of the major arteries. Next slide. Here's what's really going on. Next slide. And here's the heart. You can see on the outside those large, we call them epicardial vessels. I don't know if you guys can see my arrow pointing here. But those are the highways of the heart. Those are the big streets where the blood is going. And as you can see, there's a mesh of tiny little arteries and veins that carry the blood to the heart muscle from these main avenues and disperse it into the muscle everywhere. And that is called the microvasculature. If the microvasculature isn't working well, it can cause heart pain, angina, even like a heart attack symptoms. But it's not seen on a coronary angiogram, which is what we use to diagnose a heart attack. So you can see the discrepancy here. And in fact, microvascular disease is common in women. It can occur in men too, but it cannot be seen on a coronary angiogram. I see an interesting question. If I had that, maybe we'll get to that later, about coronary calcium. And no, we wouldn't normally expect to see, if it was just microvascular dysfunction, coronary calcium may not be there. And we're kind of talking about a calcium scan, which I think I'll go over a little bit later. Next slide. So what do we do with MINOCA? What we're doing now is using treatments that we use, medications that we use to lower blood pressure and decrease cholesterol. This is an observational trial, but we see that MINOCA patients who get statins, who get ACE inhibitors or ARBs, which are blood pressure medicines, another form of blood pressure medicines, The beta blockers the treated patients tend to have less events over time. Aspirin and medicines like Plavix don't make a big difference for the microvascular disease. Next slide. Okay, next slide. Now we'll switch over and talk about heart failure for a couple of minutes. Women and heart failure. Next slide, please. Okay, this slide shows us hospital discharges for heart failure by sex in the United States from 1980 to 2010. And interestingly, we can see that in general, there are more hospital discharges for women compared to men. Next slide. So for men, it's actually very easy to diagnose heart failure. The majority have what gets kind of confusing, what we call HFrEF. HFrEF stands for heart failure with reduced ejection fraction. So basically it's a weak heart. The heart is not pumping as it should. The LVEF is the left ventricular ejection fraction. Next. The past few decades have seen a wonderful increase in therapies to treat HFrEF. Beta blockers, which is a blood pressure medicine, ACE inhibitors, ARB, also decrease blood pressure, but help heart muscle to heal. Aldosterone antagonists, the AAs, decrease fibrosis in the heart. Then we also have special pacemakers, which improve survival in patients with a low ejection fraction. And then two very new medicines called ivabradine and neprilysin inhibitors. And lastly, even a diabetes medication, they're called SGLT2 inhibitors, which help heart failure patients. So we have life-saving therapies which have been proven to improve lifespan, actually improve quality of life in heart failure with reduced ejection fraction, the majority of which are men. Next. Now let's look at the women who have heart failure. The majority is heart failure with preserved ejection fraction. So the heart muscle is not weak. It's pumping just as well as a normal heart. So of course that makes it more nuanced, more difficult to understand, not quite as simple and harder to diagnose. Next. And we don't have therapies that are known to reduce mortality in diastolic heart failure with preserved ejection fraction. It hasn't been a priority of study, and the randomized controlled trials which have been done in HFpEF have not borne out, have not shown significant changes in longevity. A little bit improvement with quality of life with the aldosterone antagonists. Next. And so what are the common characteristics of heart failure with preserved ejection fraction, which by the way, was only defined as a real diagnosis over the, about 10 years ago or so. When I was doing my training at UCLA, I distinctly remember some attending saying to me, I don't believe, they weren't cardiologists, but they said they didn't believe in heart failure with preserved ejection fraction. It was just a bucket diagnosis when we weren't sure what was going on and a patient was feeling short of breath, which is one of the major symptoms of heart failure. Both types of heart failure cause shortness of breath, cause fatigue, swelling, but the pathophysiology is different. Anyway, with preserved ejection fraction, we predominantly female patients, older, often overweight, obese, more cardiovascular comorbidities, meaning they have hypertension, diabetes, atrial fibrillation, arrhythmia, valvular disease, and also more non-cardiovascular comorbidities, which do tend to cause the symptoms and the course of HFpEF to be worse, including anemia, chronic kidney disease, COPD, low thyroid, cancer, peptic ulcer disease, and psychiatric disorders. Next, please. So we've gone over our typical HFpEF patient, and importantly, they don't have epicardial coronary artery disease in many cases. And over the past decades, the proportion of people presenting with heart failure who have preserved ejection fraction is increased. So we have a greater proportion, in the 2000s of HFpEF compared to HFrEF. And next, reduced ejection fraction heart failure has been decreasing as the proportion, decreased proportion of the heart failure that's out there. And I believe it's that because we are having more of the risk factors for preserved ejection fraction heart failure, increasing in the United States, such as high BMI, obviously hypertension, very important to control. I was so happy to hear the talk just before me by Dr. Margolis. I believe, just as she said, improving hypertension will lower the rates of this preserved ejection fraction heart failure. Next. And then just to mention, there's other specific type of heart failure which affects only women, and that would be what we call peripartum cardiomyopathy. Peripartum cardiomyopathy is marked by a loss of cardiac contractile function in women, and it occurs either late in pregnancy or soon after delivery. Peripartum cardiomyopathy affects approximately 1 out of 1,000 births worldwide. And it is difficult to diagnose, particularly after a woman has given birth. These are young women who are being affected. And if someone isn't aware that peripartum cardiomyopathy exists, they may not seek treatment, or the doctors may not recognize it. Next slide, please. The incidence of peripartum cardiomyopathy differs depending on where you live. It has been noted to be higher incidence in the African American population, as we can see in some of these incidents. And otherwise, there may be some of the typical risk factors that are playing in to cause peripartum cardiomyopathy, but we're not wholly sure. There's probably an immunologic cause as well. Next slide. And talking about risk factors, let's go over this. Women do have some unique risk factors for coronary artery disease. So before we talk about unique risk factors, let's go over our traditional ASCVD risk factors. That's a big acronym. ASCVD stands for atherosclerotic cardiovascular disease. So we probably all know this: diabetes, smoking, obesity, not exercising, high blood pressure, cholesterol being off. We've known since the Framingham study starting in the 50s that these are risk factors for heart disease. But we're learning about new emerging, non-traditional risk factors which preferentially are seen in or affect women. So preterm delivery, hypertensive disorders of pregnancy, and gestational diabetes. So these are all things that happen during pregnancy in a younger woman, premenopausal, can portend later on, perhaps 30 or 40 years later, that this woman is at risk of cardiovascular disease. Also, autoimmune diseases such as rheumatoid arthritis do occur more often in women and are risk factors for coronary artery disease. Breast cancer treatment. Also, both the chemotherapy and radiation therapy, particularly in left-sided breast cancer, can harm the heart. And lastly, anxiety and depression are risk factors for cardiovascular disease, specifically in women. Next slide. Both men and women have diabetes, and here we're looking at type 2 diabetes in general. But diabetes, for some reason, confers a greater risk in women compared to men. I mentioned the Framingham study, just a 30, this is a study that followed men and women in the area of Framingham, Connecticut for years and looked at their outcomes. So in all these, when we look at total cardiovascular disease, if we look at heart failure, everything except stroke actually, look at intermittent claudication, which is pain in the legs with walking because of vascular disease. Diabetes has a higher relative risk in women compared to men. Next slide. This is a meta-analysis, and it's showing us that looking at all these different studies of diabetes and heart disease over the year, women with diabetes have about a 40% greater risk of developing cardiovascular disease compared to men with diabetes. So if we're looking at the pooled risk in women, they're up about, it's a 2.68 higher risk of having heart disease if they have diabetes, but in men that risk is only 85% higher, so 1.85 hazard ratio. And it seems that women with diabetes tend to have these metabolic components, metabolic risk factors to a greater degree than men. That includes like high triglycerides or larger waist circumference, all kind of coming together in women, which may be causing this greater risk of developing cardiovascular disease. Next slide. And what about women and obesity and coronary artery disease? This is part of the research that I do that I find fascinating. We do use coronary artery scans. You can see the CT scan in the corner here, and calcium, which can be seen by that bright white line, shows that there's some sort of cardiovascular disease present in the arteries there. And we're studying, is there a difference between men and women? Women are always told to lose weight, and is that the right thing? Or should we be looking more at fat mass and muscle mass and not worrying about just what their overall weight is? Next. So this research is very controversial because people don't like to look at this, but men tended to have a 4%, well, I shouldn't say tended, they had a 4% increased probability of coronary artery calcium with 10 kilogram increase in fat mass. So fat mass, not the muscle mass, was affecting the presence of coronary calcification. However, this wasn't seen in women. These are some preliminary results, but it's important that we understand this more. And it's an issue particularly to women because women tend to worry about their overall weight more than men. And anyway, I could go on about this for a long time, but I won't. I'll move on to our next slide so we can get through everything. And here, let's of course go to the elephant in the room, menopausal status. There is a definitely higher incidence of coronary artery disease in women after they go through menopause. And that was the thought that before we had the Women's Health Initiative, the thought was, okay, menopause, hormones like estrogen and progesterone are lower and heart disease is higher, we must have to give back the hormones and cause a decrease in heart disease. We found out that this didn't work. Next slide. And, okay, so we're getting—
I'm going to give you a 10-minute warning, yeah.
Great, thank you, got it. So there, why does heart disease increase with menopause? And this is a study looking at pre and post-menopause patients, and as you can see, risk factors increase with menopause. There's more hypertension, higher LDL cholesterol, higher triglycerides, higher glucose levels. women often come to me and say, like, why is my blood pressure increasing? I'm doing everything the same. And unfortunately, we can say this happens during menopause. Next slide, please. And then let's talk about adverse pregnancy outcomes, which are associated with future risk of cardiovascular disease. We've mentioned this eclampsia, gestational hypertension, gestational diabetes, preterm birth, placental abruption, obesity and excessive weight gain, sleep disorders, and a higher maternal age are all associated with increased risk of cardiovascular disease in the future. Next slide. It is as if pregnancy is a stress test for the heart, or it may be uncovering underlying vascular disease, which is going to get worse as the patient, woman ages. Let's go to gestational diabetes. Of course, gestational diabetes is associated with an increased risk of getting type 2 diabetes, but also higher risk for women getting stroke or having a heart attack. See the same with preeclampsia, stillbirth, and miscarriages. Next. As we discussed, I mentioned depression, anxiety, and even just stress in and of itself really affect women and their heart disease status. And this is the consummate example of Takotsubo cardiomyopathy, which is called broken heart syndrome. We can see on the left a full heart, and then with the heart contracting, the whole apex of the heart during systole doesn't contract like it should, and instead balloons out. And it basically looks like this woman is having a heart attack, but she's not, because the coronary arteries are normal. This tends to happen 90% of the time in postmenopausal females and occurs after a major stressor. Could be a lifetime crisis like losing a loved one or finding out a husband is cheating on them. That's one of the stories that goes around the hospital. So this is really a stress-induced cardiomyopathy. Next. Another disease etiology that looks like a heart attack and occurs in women is SCAD, just to mention this, because we're finding it more and more, spontaneous coronary artery disease. It's a non-atherosclerotic form of acute coronary syndrome. And it's basically the lining of the coronary artery wall rips, and therefore it impedes blood flow. It is sometimes treated like a heart attack, putting a stent into that artery, and of course is underdiagnosed and often not considered in younger women presenting with chest pain. It was previously considered very rare, but it's now recognized to cause 2 to 4% of all ACS. ACS mean acute coronary syndrome, such as heart attacks. 24 to 36% of heart attacks in women less than 50. Okay, also occurs in pregnancy. Next slide, please. So what are we gonna do? Well, we don't have all the answers. We have to study, we have to research, we have to advocate. Next slide, please. We looked at stress hormones in urine in women versus men on any ordinary day. And we see that the norepinephrine, one stress hormone, and the dopamine, just in this routine urine collection, was significantly higher in women compared to men. So we need to continue to look at this. Why do women have higher levels of stress hormones, which are potentially toxic to the heart? And what can we do about it? Next slide. Also, arterial stiffness, which is a known risk factor for HFpEF, that form of heart disease which affects women. Women tend to have higher arterial stiffness. This is again research from our center. Next slide, please. We saw that 3 indexes using radial artery tonometry, basically pressure sensor on one of the arteries in the wrist, the arterial stiffness is significantly higher by these 3 measures in women compared to men. And this is known to lead to heart failure. Next slide, please. The good news is there are some easy ways, or maybe not easy, but well thought out ways to prevent heart disease in women. Many lifestyle factors, for example, not smoking, exercising, healthy eating, limiting alcohol intake, having a normal body weight. All of these in women can reduce the risk of coronary heart disease. Women who engaged in all 6 healthy lifestyles had a 92% lower risk of getting coronary heart disease compared to those who didn't engage in these healthy lifestyles. Next. Also, what about exercise? And this is, again, a study just looking at women, over 1 million women in Britain's National Health Service, showing that just moderate physical activity alone reduces cardiovascular risk in women. So if we look on the left panel, we see strenuous physical activity. On the right panel, any physical activity. And we see that compared to never doing exercise, if you're just doing exercise once a week, your risk greatly decreases. And you don't even get as much bang for your buck as you go to 2 to 3 or 4 to 6 times a week doing exercise. And in fact, daily exercise, you see a little bump up in risk. I am not sure of exactly, why this daily exercise shows us, but it's been seen in numerous studies in women and men. I thought Hattie brought up a very interesting question. Is it that, one day of rest, like the Sabbath perhaps, is contributing? And I think that's really interesting and something that should be looked at that wasn't discussed in this study. But I think this is showing us you don't need to be a marathoner or anything close. Whatever you can do in terms of physical activity is going to decrease your risk. Next. I'm also, and just to show that all the lifestyle factors together can be very healthy and helpful for women. Exercise, stress management, community is actually very important to heart health, and nutrition. This shows our Ornish Reversal program, and people who enter this program spend an hour each time on each one of these modalities. And these 4 elements work in concert to decrease risk of heart disease. Next slide. We have undertaken with a former UCLA undergrad who's now working more on research, a way to teach people about preventing coronary artery disease. This was a research study where volunteers, at this point it was just UCLA undergrads, signed up to get text messages 3 times a week for 6 weeks. And the text messages were to teach and engage them in heart healthy activities. And the majority of the undergrads who signed up were female compared to male. And we thought the undergrad population was important because that's where a lot of your lifestyle activities may start. And for example, like staying up all night studying for exams is very unhealthy. So women tended to be the ones who signed up, and women had made significant gains in terms of their pre and post feelings about their heart health. Like, for example, I'm just going to talk about this first one. I am able to manage the stress in my life. We saw a significant improvement, and that will be key for their heart health as they go on through life. Next. For years, people said it hasn't been proven that statins, help women at all. And this is looking at big trials of statins in preventing heart disease in women, so people who don't have heart disease. And if you look at these 3 major statin trials, you see there's a combined 37% decreased risk of heart disease in the women who receive statins compared to placebo. So we have that data. We know that statins work in women. And next slide, please. So we need to remember that statins work in women, but also in statins and other medicines as well that we use for heart disease, women may need smaller doses because in general, we're smaller people compared to men. So we've all heard the trials have mostly been done in men, and you can't just, now we know that we can't just give women those same doses. So, you know, if we look at beta blockers for heart failure, women tend to get their, you know, tend to start responding to beta blockers and get that decreased at much lower recommended dose than men. And so we need to keep that in mind as we physicians treat women. Next slide. Yeah, so I'm sorry, those are showing us. So I'll go to our summary. More women die of cardiovascular disease every year than all cancers combined. Somehow that slide fell out, I'm so sorry, but definitely more than all cancers, way more than breast cancer. Ischemic heart disease may present differently in men compared to women and can be more difficult to diagnose. Young women presenting with heart attacks have a higher in-hospital mortality. Women tend to have heart failure with preserved ejection fraction, while men tend to have reduced ejection fraction. And there are unique risk factors for heart disease in women compared to men, including gestational diabetes and menopause. Risk factors with more impact in women compared to men include stress, anxiety, depression, and diabetes. So we definitely have our work to do, and I hope you've learned something from this talk. Thanks for having me again.
Dr. Horowitz, thank you very much. That's quite interesting. I'm glad you confirmed my feeling of having stress as measured in my stress hormones, and maybe giving me a little leeway. I do take a day off a week of my exercise, usually after I've done the most exercise. It's maybe because I'm lazy, but I like your science behind it. Now I'll use that as a good.
Good, yes.
We do have a question from the audience about the Minoka issue, and the question was, how was the absence of MI defined? Was it blood tests or?
The absence of MI?
In the Minoka.
Oh, okay, I understand, thank you. In that Minoka. Yeah, right. So myocardial infarction. It is without, so they are having a myocardial infarction, so defined by they have chest pain and they had maybe a leak of cardiac enzymes into their blood and EKG changes, but there was no coronary artery disease, meaning, now we're on this perfect picture here, we see those big arteries, and meaning there was not any major clot or blockage in those arteries that would cause them to have a heart attack. And so that's why it's called a heart attack without coronary artery disease. Does that clarify?
Yes, it does. Do you have any idea? I know it's probably multifaceted, but there clearly, as you mentioned, are differences in the pathology underlying heart disease, the coronary disease, that looks different in women, acts different.
Mm-hmm.
Are there any particular studies going on at the moment to try to figure out what the maybe biochemical underlying pathology is there?
Mm-hmm. Well, yes. I have a colleague, and we're just, we're going to get started on this, but it has been blocked by, by the stay at home, and the COVID, but she has developed a new technique of MRI, which should be able to get a sense of microvascular dysfunction and in women. And when we can pin it down and see it on MRI, we may be able to have then we can study what types of interventions can help with that, with microvascular dysfunction. I do think that, the stress hormones, are being studied in some instances as a problem of this microvascular dysfunction. endothelial function, like basically, can we just study how arteries in your arm react, and can that predict what arteries are doing in your heart?
Right. Yeah, it's a fascinating area. We always knew we were different, didn't we? We have a question. Is he unmuted?
Hi, I think you're asking me. This is Chloe. I had a question that I often get from providers who are trying to help some of their women patients lower their cholesterol, and they aren't achieving what previously were set as goals with some of the patients. And they would like to know, what's the value of using a statin when it's not getting you, you're all of the way in terms of that reduction in cholesterol to what might be a desirable level. Is anybody looking at because we see this difference in women of having more side effects from statins and so on, is anyone looking at what are the benefits in that? Because for some providers, they're caught between the trade-off of pushing on that versus addressing other kinds of concerns.
Yes. Well, it is complex, but first, yet women have more, for example, and you may have been getting at this or not, may have more side effects, it seems, from statins, and therefore may be limited in the dose that can be given them, and then possibly not getting to your goal cholesterol. But yes, statins, even if it's at even if you're not getting all the way to where you want to be, statins are still helpful, in general. We assume the cholesterol is lower than it would have been without the statin. And we have seen studies that, the lower you go on that bad cholesterol level, the LDL, the better you're going to do in terms of coronary artery disease. So even if you're not all the way there, you are getting some benefit. Another something else I'd like to bring up is that we do now have alternatives to statins. I'll just mention two of them. One is Zetia or ezetimibe, and it's not a statin. It helps lower cholesterol. And the second one are these new injectable medicines. They're called PCSK9 inhibitors. They block another part of the cholesterol production pathway and do lower cholesterol, very well in men and women. So if someone can't tolerate statins and you document it, and the physician, let's say, documents it in their notes, you are able to get these other medicines paid for by insurance. So, we usually can get the women to the level they need to be at. And, those some particular patients may warrant referral to a cardiologist.
And are we seeing fewer additional side effects or problems in women with these? Is there less gender difference in the side effects? I mean, I realize women experience more side effects from a wide range of medications, but I'm curious whether we get around that and whether we're seeing the same value, the same return.
I have not. Yeah, I haven't seen anything studying that. I really like that idea. I think that basically there's very few people who have it does happen, but the incidence is very low on side effects, especially to those injectable medicines.
Oh, good, because we see both this combination of more side effects in women and then more complex polypharmacy issues.
That's true. Okay,
in women, and so
there's certainly more interactions with the statins also. But
helpful. Thank you.
Welcome.
Okay, if we have no further questions, Dr. Horwich, thank you again very much. That was a little thought-provoking there, and we'll try to
Dr.
figure
Sager,
out how
I think we do have one other question.
We do. So are we unmuted on that question?
Let me just pull her. She doesn't seem to be in the meeting, so I think we can move on.
Oh. Okay. Oh, there is one other question. Sorry, about Vascepa. Using Vascepa in addition to PCSK9 and Zetia. If you want to make a final comment on that, Dr. Hovich, as a Vascepa.
I'm sorry?
Using Vascepa as a drug.
Oh, Vascepa. Okay. I was hearing you wrong. Yes, that is also a new medicine. Its main action is to lower triglycerides. Basically, it's a fish oil, but it's a cleaner version of fish oil because I think it's not made from fish. It's not just a vitamin, it's processed. And so it's better tolerated and it lowers triglycerides. And in that process, it's also been seen to lower risk of heart attacks. And thus, yeah, Vascepa is also a good medicine. Statins do lower triglycerides a little bit, but this Vascepa works, solely on the triglycerides or mostly on the triglycerides. So it's a great new medicine also.
Right. All right, thank you very much. We're going to transition now to our next speaker, Dr. Ria Pulakaram, who is Medical Director for Population Health at Healthcare Partners. And she's going to share not so much a population healthcare initiative, but a personal one to her. Ria, are you there?
Yes. Can everybody hear me?
Yes.
Yes.
Okay, thank you. So the first slide, yes. So good afternoon, everyone. Thank you for the opportunity to present today on the South Asian high risk of the cardiovascular disease and a patient story that's related to it. This topic is very near and dear to my heart. I'm not a cardiologist. I'm a pediatrician and a researcher. I started at Legacy Healthcare Partners in 2001 and founded their research, health economics and outcomes department, as well as the population health department. Next slide. So, after the last talk, I must say that I have, gained a lot of information, which is very important to what I'm trying to present here, as well as do in the next part of my career. So the South Asian countries are at very high risk for cardiovascular disease. And you can see that Pakistan, India, Nepal, Bhutan, Bangladesh, Burma, Maldives, Sri Lanka. This region is mainly referred to as South Asian. And they have 25% of the world population come from here, and about 6.5 million population live here in the US from South Asia. And I've also been told, and I'm not 100% sure about this, that about 50% of cardiologists come from this area, which is very interesting. Because I guess that has a reason why cardiologists are such, important people back in South Asia because of the high risk. Like, I know my father wanted me to marry a cardiologist. It's like cardiologist is like supposed to be the best profession, and they have a lot of respect. So next slide. So cardiovascular disease early onset in South Asians. So, sometimes your heart knows more to accept what your mind already knows, right? So what I wanted to really emphasize here is most South Asians are aware of the risk. We know that the risk is real. We've seen family and friends suffering from coronary artery disease. It's an important and common topic. I also wanted to talk about my own experience back in the day when I was in my mid-30s. We had a corporate wellness program, and I was very active. I used to walk, and, I was on the thinner side. So I was like, sure, I'm healthy. And we all had to do a blood test to show, what's our cholesterol. We get points. What's our LDL? What's our hemoglobin A1C? And I was sure that was fine for me because I was eating well, felt good. And when the results came, I was so embarrassed. LDL was 162 and hemoglobin A1C was 6.2. I didn't want to talk to anyone about it. I was this researcher, I was doing a lot of work in population health, and look at my own blood result. So I started questioning it back then, but then I talked to the cardiology colleagues of mine, and I put myself on, statin, very low dose, and then metformin, very low dose, and try to even exercise more and eat better. Next slide. So here I want to show my family. You can see my two sons, who's going to be 20 and going to be 18, and my mom. And, she is a very active person. She plays tennis, and you can see in the next slide, please, next slide. So she's 74 years old. She has comorbidities, diabetes, hypertension, well controlled. She's socially active, volunteers in the community, does not drink alcohol nor smoke. She's vegetarian, but she, of course, consumes coconut oil as part of her culture. Coconut, we put that in all the curries. And we grew up like that, so we have a taste for it. And, her father died of heart attack at age 50, and her mom also died of heart attack a little bit later. Her two older brothers have stents, 3 MIs, and many of my cousins have had, MIs. Some of them died, some of them have stents. So it's been of a lot of, discussion in the family. And we talk to cardiologists who always says, oh, take statin, don't worry. They look at our LDL numbers. But yet, some of them who had good LDL numbers still ended up with heart attacks. So we knew there was some issue. So lately, my mom was telling me that, she was having some breathing, shortness of breath. And then it was around that time that I started talking to Dr. Budoff on another research project. And then I attended RightCare initiative, and there was a lot of talk about calcium, CT scan. And then I started learning more about it. I discussed with the cardiologist in our network, and they said, yeah, there is, but we're not really using that much because, we have good medications now. So I was like, I went back to RightCare and I spoke to Harry and, Bob Trine, and they were like, yeah, we're doing this, very important. Harry told me about her family story. And then I talked to my mom and I said, I know your LDL is only 60, but, your cardiologist is saying it's fine, but we need to do this. We need to see what else is going on. And she was like, no, that means more radiation. I went with her to a cardiologist, and he's like, yeah, I don't think you really need to do that, Ria, because, there's still the risk of radiation. And my mom's like, no way, I'm not going to do that. Finally, I told her about RightCare initiative, Harry's family story. Finally, she agreed, and we went, and her score was 800. That was really eye-opening for me because that hit home because, I know the risk isn't very high if it's 0 or, till 100 to 300 is moderate risk, and anything above 400 is very, very high risk. So I did a scan on me and my score was 8. But in my mom's case, I felt really bad because I kind of knew about this since almost 10 years ago, but didn't take it serious because everybody said it's fine. And now my mom's score is very high. And so we did a dye-based calcium scan, and then we realized she has blocks in 3 arteries. And one is like 70%. And, so we're talking about a lot of things and what to do next. So next slide. So then we changed her, atorvastatin 10 milligram to 40 milligram rosuvastatin because she didn't really tolerate when I increased atorvastatin. So even with rosuvastatin, she's complaining of, and many South Asians have that. They complain of a lot of myalgia and fatigue after taking statins. But I told her, you got to stay on it. And I convinced her to take baby aspirin. I explained everything to her. So when she realized the score and what's going on, she was very easy to convince. And also get rid of the coconut oil. And, asked her to start using vegetable broth. White rice we eat 3 times a day, and it was very difficult for both of us to get out of it. But I had to, practice before I preach. So I showed my mom, I started enjoying brown rice, so no rice at times. So she started following those things very religiously. She kept looking at the 800 number, talking about it, talked to her sisters, everybody, we alarmed everyone. And then she exercised 30 minutes a day. And now I have to tell her, please take a break after what I know today. And then 3 months later, she came and actually told me, guess what? I don't have my shortness of breath anymore. And so thank you. She actually said, please let Hattie and RightCare know. Thank you. So I let Hattie know. Next slide.
Such a beautiful story. Thank you so much, Ria.
So, one of the things I wanted to talk about here from a South Asian perspective as an independent risk factor for heart disease is, Masala study has shown a lot, and I reviewed a lot of their results. And thanks to, UCSF and Dr. Kanaya, it shows a lot of promise and how diet can help. And, a lot of work is being done in that aspect. And there are still many unanswered questions within the lipid profile. And also from a diet perspective, I just want to say, because many people think, oh, Indians or Asians, South Asians, they're vegetarians mainly. They eat a lot of, vegetables and they're healthy. But in reality, we have very sedentary lifestyle. We don't exercise so much. And our vegetarian food has a lot of grain in it and a lot of white rice and, things like that, carbohydrate rich, and very little vegetables. So I think, a lot of education and awareness had to be, and of course the coconut oil controversy, a lot of people out there say, oh, coconut oil is the best. And then we find out that in labs to initiate atherosclerosis, they give animals coconut oil, which was something I shared with my mom recently. And she was like beside herself because she was a big promoter of coconut oil. Next slide. So, we have these unconventional risk factors for South Asians, and people normally don't talk about it, even when you talk to cardiologists, and majority of these cardiologists coming from South Asia. We have dysfunctional HDL. To begin with, we have very low HDL, and then whatever we have is dysfunctional. So that's a sad part. And then C-reactive protein is usually high. For us, even though we may look lean, we have the central obesity and bigger tummy. We attributed it to our white rice eating, but I think the adipose tissue in the central obesity contributes to the C-reactive protein. And in fact, C-reactive protein is pro-inflammatory and makes the LDL, become an aggregate and cause more damage. Telomere length, I've seen recently a lot of studies showing that we have, when these risk factors start increasing, and at age 40, all of a sudden, we start having, all these disease comorbidities coming up, the telomere length is seen as shortened. Then we have the lipoprotein A, which we still are doing a lot of work around it, and it has a genetic predisposition and control. And we really have to go after the genes, to see what is really causing this in South Asians, that, we tend to stay with less wrinkles on our face, but I guess internally we are aging much faster than other ethnicities because of these things. So I realized, I am a researcher doing cutting edge therapy, bringing new drugs to marketplace, creating guidelines in many, many disease, different disease states, being, a leader for cancer survivors, doing a lot of these things. And I have really not done much in this area. And I felt, sad about that. I looked at my kids and I said, it's their generation. I really need to start something here. So next slide. So one of the things I realized is, the common facts of today are the products of yesterday's research, and no research is ever quite complete. So maybe it's never too late. I need to, prioritize this. I need to partner with Harry and her team and, Dr. Budoff and all those cardiologists who were speaking on our behalf. Next slide. So now we've come together, we've got something in process, a study that we're still in the designing phase. So UCLA Lundquist Institute, Dr. Matthew Budoff, and you can, listen to his presentation. There's a video recording on the RightCare website. And then RightCare collaborators, of course, Harry and Bob Trine and Dr. Parag Agnihotri with Be There in San Diego. South Asian Heart Center, Dr. Cesar Molina, I just want to highlight, he's done a lot of work around this. He's in Northern California and he saw a lot of computer engineers from South Asia, ending sudden death or ending up with stents, very young. And he felt compelled that there's something else going on here, that what's happening to these young guys. And then Cleveland Clinic, Dr. Ankur Kalra, he's been doing a lot of work around this. So he is very excited to partner and see what can we go after the genes and see, can there be a new drug for South Asians? And, many of the studies haven't really gotten a lot of data on South Asians. And so we can't really put our finger to, maybe statin is not the best therapy for us, and maybe that is the best therapy. We don't know for sure. And maybe there is a genetic predisposition. So we need to know, what is the loss side? Maybe there's gene therapy in the future, so we can live without these diabetes and all these metabolic syndrome that really slows us down. Then collaboration with academic medical centers, maybe international partners in the United States and Helsinki and Cambridge. Next slide. So, we know cardiovascular disease is the #1 killer. And, we keep talking about it. But for me, especially from South Asia and my, family history, and, there is a bigger calling to commit to this. But I really think as, medical professionals, as people who are doing a lot of good work, we need to come together and try to see, how we can implement some of the learnings. Because even in my mother's case, I knew it 10 years ago and I didn't do anything about it. But I'm sure there's a lot of people out there that we could help if we intervened and said, get a calcium scan. And if you can't, then there's already information out there in databases. Like we have millions of patients in our database who've had a CT scan. Maybe we can read from that and see. So I'm going to be, involved in a lot of these as the next phase of my career, so that I can leave something meaningful for my generation and for others. So I'll stop here and pause. Thank you.
Thank you very much, Ria. That's an interesting story. That 800 number was a little eye-opening, wasn't it? Yes. I think, you bring up a lot of good points, and we do think of lean as healthy, but there is the unhealthy lean folks as well for a variety of reasons, as you mentioned. And hopefully some of the studies and further direction that you're going to help take will give us some further insight into that. So thank you very much for sharing your personal story. I'd like to move on in the interest of time for Dr. Peden to give us some perspective on where she sees issues related to what we've talked about today. She's executive director for the USC Center for Health System Innovation, and I love that word. So Carol, give us some innovative perspective.
Okay, thank you. And I just, slides please, great. I just have to congratulate all the speakers as usual on the University of Best Practice great talks. So because we're running short of time, I'm very much going to touch on some things which I think are complementary to the things we've talked about today. For those of you who aren't from LA and don't know Keck Medicine, we're the third perhaps academic medical center in Los Angeles with Cedars and UCLA on the west side of LA, and we're in the east side of LA. Next slide, please. So what's happened in the space of a few weeks to transform healthcare? Well, I don't need to name it, but the virus, you know, hopefully is not everywhere, is decreasing, but it has really changed the way we deliver healthcare. Next slide. And next slide, next. So number one, what we had to do was, like everywhere, to adapt our facilities to safely care for patients. Think about surge capacity, triage, and testing. Next. Providing resources to staff, and like many places, we were watching, particularly Italy, and there was a lot of fear amongst staff. And I'm going to talk particularly just very briefly about our Care for the Caregiver program, because I think we've talked about stress, and particularly many of our caregivers are women, and what we focused on to ameliorate that stress. Next. And then just to complement the first talk, very, very brief touch on telehealth. Next slide. So we were very, very conscious of the PPE issues. We have very generous donors and supporters at USC, so we reached out to those. We reached out to the university, places like our Viterbi Engineering School, and you know, we have been fortunate. But again, talking about that caring for caregivers, one of the things we've learned very much during this has to be very transparent. And people were hearing the news from other parts of the world and other parts of the US that PPE was running out. So we publish every day how much PPE we have. And when you see these numbers here, that's actually days of availability. It's not numbers of masks, it's numbers of days that we can provide for all our staff. And we publish that every day just to reassure people that they're going to have what they need. Next slide. We've worked very hard on our Care for the Caregiver program. Because the university has a hotel which was empty, we can provide rooms for our staff, and that's all staff. It's not just nurses and doctors, because people like IT will be up on the floors. So anybody who wants it can stay in the USC hotel for $30 or less, depending on their, you know, who they are. I think many staff it's for free. And if you're worried about going home or you live with elderly parents, you can stay there. We've also offered that to our partner, LA County, as well. We've just made up and distributed a large number of comfort kits with lots of nice treats, just to make people feel, our staff feel, we're really thinking about them, and to build that sense of community that we're all in this together. Next. We've also started things like a legal assistance program, an online tutoring program using the university resources for school children, emotional well-being, housing access, music as medicine. All these things are available to our staff and our team members. And just, again, focusing on this PPE, that this is a team together. You work, if you're doing PPE, with somebody who observes you donning and doffing to make sure you're doing it safely. Next slide. And for those of you who are into improvement in healthcare, you know that it's always good to celebrate people and celebrate success. So again, we've been calling out our teams, making people feel special, and just getting this sense of community to get everybody through this. And so we're empowered to look after our patients as safely as possible. Next slide. I'd also like to comment, we're very lucky in that we're members of a group called Global Health Data, which is a group of hospitals around the world, grew out of another program. We know each other, so we can be open and sharing. You might have seen the talks and papers by Maurizio Ciccone, who's an anesthesiologist and intensivist from Humanitas in Milan. And we had one-to-one sessions with him and his team very early on in this, and we learned very fast what they were doing. So at Keck, we were 2 weeks ahead of getting everybody to be masked. Everybody in the hospital was masked because we heard it from Humanitas on our working together. Next slide. It's just the Global Health Data. Next slide. And we've done those talks regularly so we can all meet and share very openly about what everybody else around the world is doing, and then we can put it into practice for us. Next slide. And then finally, and this is by no means unique to us, everybody across the world, across the US has had to do this, and it's been phenomenal. All the barriers we had before to telehealth and interesting, very much complementary to the first talk, have just fallen away. We, in the space of a couple of weeks, launched 88 new clinics, trained 600 providers, established a command center, distributed hardware, launched new patient resources. Next. And you can see here, this is a fairly up-to-date data. We've gone from 10 telecare visits a day prior to COVID to over 900 a day, with a lot of high patient satisfaction. We're monitoring that. Next slide. And just to see the speed of the ramp up, this is a paper we're publishing in Journal of General Internal Care Medicine. It really happened at the sort of end of February when we saw what was coming, and it was incredibly fast, this ramp up. Next slide. So, and I think worldwide this is going to change, and I really hope it is going to change. We're going to take the good things from this crisis and change the way we deliver healthcare and make it much more person-centered, exactly like the blood pressure monitoring we heard about initially. Next slide. So in summary, we've done a lot of rapid adaptation and innovation. We thought hard about caring for our caregivers, learning from each other, and the importance of communication both within our organization, and transparency about our data, our preparation, and celebrating the good things in the sense of community. So very brief run through, but thank you.
Thank you, Dr. Peden. That's fantastic. I think you bring up some very good points that, we talked earlier about how we're trying to change, hypertension control and the risk factors for cardiovascular disease. And we seem to be moving at a snail's pace, yet here in this pandemic that we haven't personally been involved in one for over 100 years, although those of us who are at home and staying at home feel like it's forever, you have remarkably moved quickly, as has a lot of medicine. And I think we've shown that we can do that. And you're right, medicine will be changed, hopefully for the better. I'm looking for a silver lining in COVID here. And I think what you've shown is how we can really muster our forces when we really need to. So thank you very much for that perspective. I know we're running a little late on time. Dr. Kuo, do you have a perspective that you'd like to add to our summary?
Well, thank you. Can you hear me okay?
You're a little muffled.
Can you speak up a bit?
Can you hear me?
We can hear you, but we need you to be louder.
All right. I'll speak a little louder. I'm going to be relatively short. Unfortunately, I have to probably get off soon. But I will say that it's been an excellent panel of presentation. I think many of the topics that's been addressed have been both challenges and advancements that's been made by this group and other group throughout, even before the COVID-19 pandemic. And I think that because of this health crisis and moving forward, some of the innovations that we've talked about, everything from home blood pressure monitoring, women's cardiology, and some of the things we're trying to do becomes actually even more important. As you know, if you've been monitoring some of the science and data that's coming out, comorbidity is quite a big risk factor, or a series of risk factors. Hypertension, cardiovascular disease, actually at the very top, that seem to go hand in hand in how severe the coronavirus 2019 infection can be. I know in the Department of Public Health, we continue our response, and three of the areas you probably hear in the news that we continue to work on is those people who are in nursing homes, the homeless, and of course, many of the vulnerable groups that are actually incarcerated or in correctional places. So my perspective is that I am really glad to see the continued work on this, and I certainly think that USC and Carol, as Carol had mentioned, has done a marvelous job in making some of these conversions, and so has other hospitals and health systems in LA County. So I'll stop there.
Thank you, Tony, very much. Well, I have to say I appreciate the information that's been transmitted from all of our speakers today. I think the topics really blended well into what our missions are, and then from the Right Care Initiative perspective, as well as just healthcare in general. And I think if I were to send a couple words, it would be alacrity, as we've had a response to COVID, putting that into other aspects of medicine, and really looking for innovation that we can translate to the source of where the provider meets the patient, whether that be telemedicine or in person. So is there any other comments from anyone on the panel, or I don't see any other questions? Any other final comments? If not, then I will say thank you all very much. Stay safe out there, and we will reconvene on June 8th and 23rd. All right, thank you all.
The beautiful
Bye.
presentations. Bye-bye.